Great. So once again, welcome to the session where we're going to be talking about lifetime management of aortic stenosis. I'm joined today by Mike Reardon, who's co-chairing the session with me, and we have an incredible faculty who are here with us, and we'll introduce them as we move along. So these are my conflicts of interest. So really the objectives today is to talk about valve selection and how valve selection impacts lifetime management of patients with aortic stenosis. We also want to talk about how we think about valve selection when it comes to patients with small versus large annuli and what the differences are. And then also, as we think of lifetime management, it's about giving patients valves that will last longer, but also how do we maintain coronary access after TAVI and for future TAVI and TAVI. So again, you're the rest of our faculty. I introduce you to Mike. On this side, we have Bassem, Kamran, Grant, and Amar, who will be helping us through this session. And we'll start the session really with talking just very briefly, so we set the stage, about the Navitor Vision Valve and the FlexNav delivery system. So for those of you who don't know the valve, here it is with its main design features. And really what stands this self-expandable technology from others are highlighted here, but I'll highlight some of them. So really this is an intra-annular valve and with intra-annular leaflets, but as you'll see from some of the discussion, this doesn't behave like an intra-annular valve we think of when it comes to hemodynamics. We have multiple sizes and can treat from 19 to 30 millimeter annular diameters. It has a large cell design which allows for coronary access and improved coronary flow. I think one of the interesting features for me certainly using this technology has been the active sealing cuff, which does mitigate PVL better than many other technologies. It has consistent radial force, and now with the vision we have these three radiopaque markers that really allow you to see your implant depth and aim for a 3 millimeter implant depth. In order to get the valve there, just as important is the delivery system, and this technology has an integrated sheath with a 14 and 15 French delivery system depending on valve size, a very flexible capsule, shaft and atraumatic nose cone. The handle is very ergonomic, and it has now a stability layer that allows for precise and stable deployment. Here you see these vision markers. That's been the biggest difference going from the Navitor to Navitor Vision, which show you where 3 millimeters are and allows you really to plan your implant depth and get more reproducible and accurate implantation depth. As I mentioned, this is really the delivery experience with this has been consistent across valve sizes, 14 French inline sheath for the 23 and 25 valve, and 15 French for the 27, 29, and 35 valve. So when you go to 35 and really large annuli, you still maintain the same sheath, which really, to me, when you want to treat large annuli and need a large valve, this is the technology that has the best delivery system and the smallest delivery system, really, to allow you to implant a large valve. We have some 30-day outcomes from Navitor already from the Portico NG study, and really 0% moderate or severe PVL, 1.9% all-cause mortality. Remember, this was a high-risk study, 1.9% disabling stroke, 4.2% major complications, and really the dramatic part has been the hemodynamics with a gradient of 7.4. So with that, I'm going to hand it over to Grant, who's going to take us through the case presentation.
Okay. Well, good afternoon, everybody. And this case will set the stage for illustrating a lot of the most important details about Navitor implantation. We're going to keep it pretty brief. Here are my conflicts of interest. So this is a 70-year-old male with severe symptomatic aortic stenosis, class 2 symptoms. Pretty typical patient for us in many ways. Is 70 years old. So when we talk about lifetime management considerations, this is an individual who very likely will outlive the durability of whatever valve is implanted. Right? Has severe aortic stenosis, as mentioned, with an elevated coronary and CT aortic valve calcium score at almost 2,000. Has normal sinus rhythm and conduction is good, but also has an elevated BSA. So this is a 70-year-old patient with severe AS and an elevated BSA, which may make hemodynamic considerations especially important. This is us playing through the annulus, as you can see. The annulus measures right around, depending on the phase and how you cut the calcium, between about 4.3 and 4.4 in terms of the cross-sectional area, with a perimeter of approximately 79 to 80. But there is some pretty heavy posterior annular calcium, which further complicates the decision about whether or not to use a self-expanding valve, which may be safer, or a balloon expandable valve, which may have an increased risk of annular rupture. Otherwise, however, the dimensions are favorable for TAVR, and femoral access is also quite favorable as well. However, the common femoral artery is quite calcified, as you can see, with an MLD of 6.2, with posterior and medial calcification, which could actually complicate using perclose for closure. So our procedural plan was to use a 29 millimeter Navitor valve. This goes through a 14 French sheath, which we will exchange for a 15 French FlexNav delivery system. And as customary, at least in our practice, we'll deliver a 14 French sheath up front just to do our crossing of the valve and balloon aortic valvuloplasty. And if that passes, then we feel confident that the FlexNav delivery system will pass as well. It's really a pretty wonderful system. And, as we have, and in my practice, have discovered that it actually advances through tortuous and calcified anatomy quite well. We weren't specifically worried about that in this case. And as long as you have a 14 French sheath which passes, you feel confident that the 15 French FlexNav delivery system will pass as well. In all of my cases, I use ipsilateral access, in which the superior access site is used for the large bore access for TAVR delivery, and the inferior access site is used for access protection as well as aortography during the case. So we place a pigtail in the non-coronary cusp for the cusp overlap view and implant based on that, and that's a standard practice at the Cleveland Clinic. Use a single perclose for a pre-closure technique, and with the Navitor delivery system, we found that a single perclose is all you need. There's obviously practice variability in this, and some will use MANTA, but a provisional approach where a second perclose, if needed, or an angioseal, which is my preference, afterwards works very well. So you don't need to make any special changes. You can do TAVR as you normally do, use a single perclose, and it works well in all of our cases. We used an Abbott Circulo guide wire for deployment, which is the Abbott wire, which works really, really well, has a nice pre-shaped curve to it, and allows for stability during deployment. And based on the angular dimensions, decided to pre-dilate with a 20 millimeter balloon. We also use a sentinel for all of our patients. So we save the right radial access for sentinel deployment. This is, again, standard protocol at the Cleveland Clinic. Not any specific high-risk features for this, and that's not Navitor specific, but it is in the patient's best interest as we believe. So that's a procedural plan. I think it sets the stage real well for the conversation of lifetime management, as well as the case coming up.
Great. Thanks, Grant. Appreciate that. So, Mike, let's start with you. 70-year-old patient, high risk, particularly because, I guess, the BMI. And, I mean, what are your thoughts when you see patients with high BMIs about valve selection? I mean, I guess surgery versus transcatheter, and then maybe we'll go and talk about different transcatheter valves.
Of course, he's a young guy because he's younger than me, so that makes him young. He is a big boy, but big people tend to have more complications and not more death. But you also really worry about getting the best EOA that you can and avoiding patient-prosthetic mismatch, which we have decades and decades of experience with in surgery. Fallon looked at 60,000 patients that were 65 or older getting isolated aortic valve replacement and showed that any level of aortic patient-prosthetic mismatch, moderate or severe, decreased your survival and increased your risk of being rehospitalized for heart failure or aortic valve intervention. So you're thinking about, what am I going to do with this guy? BMI does make you want to not operate if you can. And what I really look at is I look at how long do I think this patient's going to live? What's the lifetime expectancy of a 70-year-old guy with these things going on? Now, I was in Sweden recently, and I gave a talk, and the guy before me was a young cardiologist, and he said the average Swedish guy who's 70 lives 12 more years. I said, wait a minute. I'm 72, that doesn't sound right. There needs to be more years. But in Sweden, they actually have a sweetheart database where everybody that gets surgery in TAVR is recorded, and by law, all deaths are reported. And what they showed is if you were higher intermediate risk, no matter what age you started, your mean survival never passed 10 years. You had to be low risk and younger than 75 before your mean survival went past 10 years. So if you think you're going to have 10 years survival or less, TAVR always makes sense to me, always.
Bassem, when you see patients and you're seeing patients in the office, how much does BMI and the risk of patient prosthesis mismatch play into your decision as to what valve you're going to be choosing for a patient?
I mean, no, this is crucial for us. I mean, I practice in Kansas. I mean, the BMI of 31 is like a 24 for other places. So we actually have to tackle much more bigger BMIs. And I mean, we've had BMIs in the 40s pretty consistently. And these are the one where really this hemodynamic thing and patient prosthesis mismatch is crucial for these patients. And we're always very cognizant about when we see someone with the BMI above 30 in our program.
And so maybe I'll go one step further. I mean, do you ever, calculate or have a chart or look at what the different gradients are that you're going to get an EOA based on the BMI when you look at a patient?
Pretty consistently almost, because we face that problem consistently with our program.
Okay. Amar, what about at the Cleveland Clinic?
I think taking a cue from most people that work in Washington, D.C., I'm going to answer your question without really answering your question. I think that BMI and EOA and gradients are an important part of the TAVI choice. I think especially if we're talking about somebody who's 70 who may outlive their valve, I think it's one of the considerations. In addition, first of all, just optimizing the first valve placement and reducing pacemaker risk and making sure that they have a good outcome of that case. But also taking into consideration the root anatomy and so forth and understanding whether a TAV in TAV is possible, what does it mean for coronary reaccess in a particular patient. For the patient that Grant presented, a couple of the factors specifically, at a 4.48 centimeter square area, it's really just a little bit too big for a 23 balloon expandable valve. It's a little bit on the small end of a 26. And adding that to the posterior LVOT calcium, personally, I think the safety of the self-expanding platform is something to really consider here. When you add to that the root sizing that will allow the use of a 29 Navi and the placement of a TAV in TAV in the future, I think that there are a number of factors here that push me towards this platform versus a different.
Well, that's a great comment. Kamran, often when we do, Grant mentioned 70-year-old patient, we're thinking about coronary access, and we're thinking about future TAV and TAVI. Often when that discussion comes up, people go, oh no, I need the shortest valve possible, right? And because that will allow coronary access. Is that something that plays into your mind, or do you think, when we look at the Navitor technology, I showed some of the characteristics. How challenging is it to have coronary access afterwards?
Yeah, I think it's a great question. We know that a good proportion of patients undergoing TAVR will have need for coronary reaccess, 5% or so risk of ACS in the coming years. And this is a younger patient with risk factors, so I think that should definitely be a consideration. And then, as we discussed, this is an intraannular valve at its core. It has a short risk plane and big cells to allow easy access to the coronary artery. So it sort of brings the best of both worlds. It has supraannular hemodynamics, if you will, based on its design, its non-tapered design, but it is intraannular in its profile for coronary access and a risk plane for considerations of future revalving. So I think it's a nice blend. And in this day and age where we're seeing younger and younger patients on one end, but on the other end, very complex anatomies like TAV and SAV, it's good to have, in my opinion, more tools in your toolbox. And I think this is definitely, the Navitor valve is a very useful tool to tackle all these problems we're going to be facing.
Mike, you've been involved in so many different valves, and you've seen so many different valves. And Kamran just mentioned, this is an intraannular valve. And generally, when we think of intraannular technologies, we think of maybe, hemodynamics that are not as great, right? Maybe slightly lower, higher gradients, slightly lower EOAs. Is that true of Navitor? And if not, why not?
Well, it's not true. I mean, the data is very clear that the gradients and EOAs are very similar to a supraannular self-expanding valve. And I think it's the valve design. I mean, the valve design is more cylindrical, and it puts remember, you can't compare the number the number that they give you for valve size is not really the size of the valve. It's the size of, for some of it where the inflow is, not the valve itself. So it actually, the hemodynamics we see are exactly the same as we're seeing with self-expanding. Now, I want to make one more comment on coronary access. When you send somebody to me for an aortic valve, I put a valve in that gives you easy coronary access. Why do I give you easy coronary access? Well, not only is the valve relatively short, but I line it up the way that God intended the valve to be lined up. And you can do that with this valve. You really can't do that with balloon expandable valves, at least at this juncture of the time. So I think as we talk about coronary access, getting commissure alignment, coronary alignment, to be more specific, becomes really crucial for the interventionist in the future if somebody does have an ACS or need intervention.
Well, I just wanted to, again, just maybe focus a little bit, Bassem, on this intraannular technology and kind of what your experience has been. Because, again, I think one of the messages I want people to leave with today is that, not all intraannular valves are the same, right? So maybe your thoughts when you've seen patients in follow-up, what kind of gradients are you seeing? What kind of EOAs are you seeing in clinical practice? Because, I'm going to show in a second some of the data that Abbott has, but real-world data is really what counts as well.
No, that's crucial. I mean, it's intraannular, but it does not behave like an intraannular. I've been doing Portico or Navitor since the early trials with the IDE, and 2017, 2016. So we have almost 9-year data so far, and I keep seeing a lot of these patients, and they come back, and I mean, I've seen patients at 8 years, 9 years with single-digit mean gradient still, which is unbelievable. And I mean, as EOA is always above 2, DVI is in the 0.6, 0.65. So I love how that valve behave. It gives me, Kam said, supraannular hemodynamics while being intraannular and giving me all the options for future lifetime management.
Yeah, absolutely. Could you bring up the slide I have on someone from the meeting? Yeah. So this is just some data. I wanted to highlight kind of what you said. Here, just showing again the gradients and the EOAs for different valve sizes, and what you see with this technology is really consistently single-digit gradients at follow-up, and EOAs that are really spectacular and more than we would normally expect with an intraannular technology. And I think a lot of that has to do with the design of the frame, but also the leaflets and how they've been placed inside the valve. And I think for all of us who use this, we've really seen this consistently across valve sizes in our patients. So I just wanted to highlight that. One other slide I wanted to highlight, and I wanted some comment. So this is data, again, this is from Mahoney, again, showing PVL rates. And again, PVL rates for different valve sizes. And so we're seeing here almost no moderate or severe, none or trace in 80% of cases or more with this technology. To me, that is really as good as it gets. Is that what you guys seeing in clinical practice? And is that just the technology, or is it related to implantation technique? Amar?
I think there's probably two aspects to this, right? One is the valve design and the skirt certainly allow us to provide optimal results. But to me, one key is the predictability of deployment. And I'll just say, in my experience with self-expanding valves, this sits exactly where you think it's going to sit when you've gotten at the 80%. When you let it go, it's not going to go a little bit lower, a little bit higher. So it's been quite predictable to stay where we want it to. And to be honest, the other thing that relates to this is we have an experience of about 150 Navi cases in Cleveland now, and our pacemaker rate with the Navi is between about 4 and 4.5%. So I think the PVL and the pacemaker are both related to this predictability and deployment that we've seen.
Yeah. Well, I think that's maybe a great...
Well, Azeem, can I make one more comment about, I think you need to think a lot about the frame and how the frame interacts with the heart. You know, the aortic annulus, just like the mitral annulus, is a very dynamic thing. If you put anything rigid in there, whether it be a stented surgical valve or a rigid cobalt chromium frame, it eliminates the aortic mitral interaction. They can't, normally when your heart ejects, your annulus gets bigger. If you put these valves in an MRI, you can see that the annulus still moves. And it moves like more like a normal annulus. It still interacts with the mitral annulus. And so I think you got to think that it's the leaflets too, but this frame acts fundamentally different than any rigid frame, whether it be a cobalt chromium or the Lotus, which was a rigid frame. Mm-hmm. You know, those are intraannular valves that had issues, but I think it's as much the frame as anything else. Your aortic annulus is a very dynamic structure, and the nitinol allows it to continue to be a dynamic structure.
Right. Thanks, Mike. I'm going to take your point, Amar, about the Cleveland Clinic pacemaker rate, you know, I mean, and implant, and how you say that this is so reproducible to transition to Bassem, because I really do think implantation technique is fundamental. I mean, all of us know that pacemaker rates can be high with self-expandable technologies, and predominantly that's related to implantation depth. So there really is a technique for this technology. Not all technologies are the same, and not all self-expandable technologies are implanted in the same way. So Bassem, maybe give us some tips on how we get the best out of the Navitor technology.
No, thank you. Here we go. So I definitely echo what Amar said. You know, implantation technique is crucial, and the valve is very, very predictable. No matter how the valve is predictable, you know, there's always certain operator thing that can optimize your procedure. Because the goal in here is just to deploy the valve where you want, minimize the resheathing, and also have the best outcome from PVL and pacemaker rate. Like Azeem said, this is not like other self-expanding systems. So really the way to do that is just to cast away a little bit some of the stuff we know about other self-expanding platform and deploy this valve as its own class of valve. It's so important to start with that first step, and that first thing in the mind is just this is the different platform. And you know, depth is going to be important, and that's why the predictability in the depths can be so important with this platform. This platform requires pre-dilatation. It's so important to pre-dilate, and right now we almost pre-dilated the mean diameter, maybe -1 millimeter, sometimes up to the mean diameter, because it helps the valve really deploy in the right place and expand properly and minimize any kind of bunching on the system. And this also minimizes conduction abnormality with the electrical system by doing it that way. So crucial to pre-dilate. I think it's a must, and no Navitor deployment should be done without proper pre-dilatation. Cusp overlap is a must. If there's something we can take from other platforms, we've learned that how much important cusp overlap is. And of course, because of the depths and minimizing depths, cusp overlaps can be very important. Removing the parallax like you see in the step 2 in here. And very slow, steady deployment. That valve is very stable. It becomes active very early hemodynamically. There's no need to rush anything. The faster you deploy, the worse things can get. And slow deployment are very predictable. While taking the parallax, sometimes I pause my deployment, I go LAO view, RAO view, make sure I check my left coronary cusp, I check for bunching on the system, and adjust my coaxial thing before I complete my 80% deployment. At that time, like Amar said, I confirm my 3 millimeter depths. And then once you're at the 80% deployment and you like what you like, then I definitely proceed to the final deployment. The valve's going to stay exactly what it is. And then I go and I do a very slow final release, sometimes with very mild pacing to minimize any PVCs. And then I confirm that all my returner tab has been relaxed, and then centralize my nose cone, and that's the valve gets deployed. So really, it's very simple. It's its own class of valve. Always watch your depth. 2 cusp overlap is very, very important. Pre-dilate, pre-dilate, pre-dilate. And usually my post-dilatation rate is almost very minimal on this kind of valve. Thank you.
Thanks, Bassem. So Grant, show us how it's really done.
Sounds good. Sounds good, guys. Okay. All right, so we're gonna get started with the case. Okay. And welcome to OR 81 at the Cleveland Clinic. We're very excited to present to you a 29 Navitor case. We already have radial access, which we use for our Sentinel device. And now we're going to start with normal access. Our usual approach here, we do a same side access, ipsilateral approach, such that we put our large bore access for the TAVI delivery in the superior aspect of the femoral head, and we put a short, usually, in this case, a long 5 French sheath in the inferior aspect of the femoral head for access protection and for angiography at the end of the case. So we're going to go ahead and get started. So just as expected, a pretty perfect spot for us to do our case. So ultrasound is wonderful and it works like a charm. In this case, again, because we have a very clear picture to start and we have fluoroscopic landmarks with the calcium, it makes doing access very easy and safe as well. At this point, we have all of our access. We're just going to put our 6 French or venous sheath in. So we're in a great location here. There's the RV apex. And that's sentinel deployment. Took under 2 minutes, maybe putting in an angled pigtail catheter in the inferior 5 French sheath, which will go in the non-coronary cusp. Next, we're ready to do our upsizing of the 8 French sheath to a large bore access. In our case, we use a 14 French centurion sheath, which serves as a placeholder, allows us to cross the valve, do balloon aortic valvuloplasty, and we have reasonable reassurance that if the 14 French sheath passes, then the 29 Navitor system will pass as well. It's encouraged that you use the perimeter-derived mean diameter to predilate with the Navitor. So in this case, that'd be approximately 22 to 23 millimeters. We're going to choose a 20 millimeter balloon because the annular calcium protrudes in a way that restricts the minimum diameter at that point. Okay, we are off. So good. Okay, well, ready to go. Okay, can we pace at 180, please? Very good. All right, off pacing. Very good. So we're ready to take the sheath back. We'll hold pressure, and we will deliver the Navitor. As you can see with Dr. Yun, he's loading it up. It's a nice, slippery, hydrophilic sheath that we introduce the entire way. So as we're going to advance, and what I'll call the captain, I'm going to be the captain of the ship here, so the operator on the wire actually has a very important role. So wire control is really essential when it comes to adequate and optimal Navitor deployment. So the first operator advances the Navitor system, and we want to see that the valve is biased to the greater curvature of the aorta, because that'll serve as a nice anchor point. So we'll do this in an LEO view, and we'll deliver the valve. We'll then switch to our cusp overlap view, which will be the view that we use for implantation. And at that point, we'll take a very brief aortography, really a cuspogram, just to make sure we're in the proper location, and then we'll start to unsheath the valve. So those are the steps that we're going to follow at this moment. I'm just zooming in so you can see the sentinel as well. Just tug on the wire a little bit so it's off the greater curve or the upper portion of the arch. Very good. So very nice delivery there. This is really a team effort, a team approach. So, as the captain, the one driving the deployment, I'm going to direct Dr. Mentias to do my hands up front, and Dr. Yun in terms of his dialing of the knob and delivering the device. And I'm going to work the wire. And working the wire is actually one of the most important aspects of valve delivery. If the valve needs to go in, I generally pull on the wire, and Dr. Mentias says some gentle forward pressure up front. And if the valve needs to come back, then he lets up on the pressure up front, and I push on the wire. So it's not much of a pull on the device because we want to make sure that the device does not centralize because the deployment is not as stable. You want to try to deploy the valve in a way that keeps the pressure on the greater curvature so the deployment is very stable, and that's going to be your touch point. And in fact, if you need to do a recapturing of the valve, if it is too low, the general recommendation is that you do a full recapture and you reapproach it such that the pressure is on a greater curvature. Whereas if the valve is too high, you can do a partial recapture, do a gentle tug on the wire, and then it will migrate down, then you can finish your deployment.
Starting.
And once we're through this first bit of dead space, then we'll be a little slower with our deployment. The valve tends to migrate in a bit at this step. And what you see here are the 3 markers for the Navitor device. Those are the vision markers. It's a really nice addition. You can pause there, James. So,
pausing there.
so the vision markers are about 1.5 millimeters in height. So the base of the vision marker is 3 millimeters of valve beyond that, whereas the top of the vision marker is 4.5. So our goal in this case, where we're trying to exclude a little bit of that angular calcium, is to land between 3 and 5 millimeters of depth, which should mean having those vision markers right at the base of the pigtail, which marks the lowest part of the aortic valve annulus and will allow us to have a 3 millimeter depth. So very important that we have a nice, slow, steady deployment at this step so we can minimize the risk of stent under expansion. And this, I think, is a pretty nice spot. We have great pressure throughout. Again, one of the real nice things about the Navitor. Just lean on it a little bit there. At this point, what we can do is pan to an angle that allows us to get the parallax off so we can better assess where our markers are, okay?
I think
And
we're
this-
pretty good. We'll see.
This may not be the same angle that we used for initial deployment.
Okay, we're right at the 80% here.
Very good. So when you get to the 80%, you can hear a click, which is very nice. It's important that you don't press this button until you're ready to finally deploy, because this will allow you to go from 80% to 100% deployment. But this serves as a locking mechanism, so you will not fully deploy the valve until that is depressed. So at this point, we're going to assess with parallax off the valve and make sure that we've fully opposed to the annulus and that we have positioning exactly what we want, okay? Okay, team, so we have full contact to the entire aspect of the annulus. And an important point we want to mention is that you want to make sure that there's not what we call non-uniform expansion or stent under expansion of the Navitor valve. The Navitor valve expands. When it's fully expanded, there are 9 posts which are clearly visible. And here is the base of the valve. You can see 1, 2, 3, 4, 5, 6, 7, and there's probably some overlap. But the important thing is that these posts are evenly distributed, and there's not bunching on any one side, which would suggest non-uniform expansion or stent under expansion. We'll keep the pigtail as is, and we'll do our final deployment.
Okay,
So-
final phase of deployment. We push the button.
We'll push the button, and this is really important, just to go very slow. So quarter turn at a time.
Yeah, so at this point I'm doing just a quarter turn at a time, watching the fluoro and seeing how the pace of the release of the top part of the valve is progressing, with the goal of not having too much energy unwind all at once. We're trying to make it as gentle as possible.
Yes. And when you have the bunching of the post to one side, or this non-uniform or stent under expansion, you get more movement in the final deployment stage, and that's why it's so important.
Slightly positive.
It's almost like uncorking a champagne bottle. So especially with a deployment like this, which is just really perfect right now, you're right at about 3 millimeters of depth of deployment, you want to make sure that you don't have non-uniform expansion, because things can move, and that's when you get into a situation of embolization. And again, as long as you have proper implant technique, and I will internalize the wire here, okay? This should be done in this final step of deployment as we're talking, okay? Internalize the wire so things are nice and central. Then this should not happen, and I think following best practice technique really helps you get the optimal height, the best outcomes, and minimize the risk for these events which
There's one tab out there.
shouldn't happen if you plan carefully. So here you can see the Navitor starting to release its upper crown, and you can see one of the commercial tabs is released.
There's 2.
2 of them are released. The third one is probably still caught. So we're going to just pause and make sure that we're fully free, and we're good to go. Recapture. So here we go. So Dr. Nguyen will now recapture the system. Very good. Great. So we're recaptured and we're ready to go. This looks fantastic. Really a perfect deployment, approximately 3 millimeters deep off the node. You can see that we're slightly deeper off the anterior aspect, but that's expected with the non-cusp overlap technique. So with that kind of angular calcium, with that heavily calcified valve, you really cannot hope for a better result. So we're very, very happy with this. In a case like this where you really would not want to use a balloon expandable valve for several reasons, because of the angular calcium risk of rupture, but also the fact that it would be a 23S3 and it's a small valve, and here we have a 29 Navitor in this patient. Even the dynamic result is so much better. You can see it's really a perfect closure despite the moderate common femoral calcifications. Well, this has been a great case, and it's been our privilege presenting this to you. This gentleman, a perfect result with a 29 Navitor valve. We thank you for your attention and enjoy the rest of CRT.
Well, thank you, Grant. Just what we'd expect from the Cleveland Clinic, a perfect case. So we've seen a couple of really interesting things today. Dr. Latib has shown you the valve and delivery system. Dr. Chehab has showed you, the perfect steps to put it in, and Dr. Reed now has shown you how easy and stable it is to put this valve in. And Dr. Krishnaswamy has told you that his pacemaker rate is very low. You can see from this design that coronary access with commissure alignment should be fairly easy. So great valve, but it's a tissue valve. And all tissue valves, if you live long enough, will fail. And so the question becomes, if it fails, what do you do? We have a couple of options. One is to put a TAVR valve inside the TAVR valve. Another one is for me to take it out and put a surgical valve in. So if all things were equal on the panel, what would you do? TAVR and TAVR or TAVR explant, if all the other things were equal? That's an easy one. That's a throwdown question.
Very easy.
Even from a surgeon.
Well, I think, it depends on the patient and the anatomy.
All things are equal.
All things are equal. Well, personally, I would try to put a TAV in, and I think maybe it's a leading question, but...
It is a leading question.
in this case, as we talked about the intraannular design, the low-risk plane, this case was very favorable with big sinuses. I think this technology, Navitor, lends itself well to future TAV intervention.
So let me make the throwdown question even easier. If all of you thought that you could get the same result and anatomically it was good, would anybody send them to me for TAVR explant and surgery? Anybody? Raise your hand.
So, Mike, the only time I might consider it, right, is if I had implanted a 23 millimeter Navitor valve that now had failed and the patient was still a surgical patient, because I've got to think about what my options are for that patient. And would you be able to give that patient a better result? Or would I be able to give that
answer is
patient
yes,
a better
but we're
result?
talking about a patient that you think you can get an excellent result both ways. And the point is that if you get an excellent result both ways, nobody's going to send them to surgery. So now the question becomes what would make you send them to me? And you've just said one thing. They have a very small valve in there, and you're going to put a smaller valve inside that, and they may have started with some significant patient prosthetics, Mr. Matz, that's going to get worse. And yes, I can take that valve out. I took out a 20 S3 not too long ago and did an annular enlargement and put a 25 pericardial valve in. That's really not that hard for us to do, but it's a big operation in some of these older people. What else would make you send them to me for surgery?
I think one important thing is, if it were a small valve and this patient had 20 or 30 years of life, right? I mean, in that case, then potentially getting a larger surgical valve in, setting him up for a better valve-in-valve TAVR in the future would be it.
Yeah.
In this patient, I don't think that there would be a strong reason to.
Yeah.
But if you had a really young patient who is low risk and you really want to plan for lifetime management, that might be a consideration.
One would wonder why they put a TAVR valve in somebody that was so young that it failed and they're still got a lot of lifetime left, but that's a separate issue. But now let's take somebody that has a good-sized valve in there already, and they're going to live another 12 years. What else would make you maybe send them to me? What other anatomic or physiologic things would make you say, I don't want to do a TAVR and TAVR?
I think either if the coronary is one possibility, and the other is if they've had an early valve failure. I think unfortunately with any valve platform, whether surgical or transcatheter, we sometimes get these patients that have an earlier failure than we anticipated, maybe within 2, 3, 4 years. Yeah. I don't know how long a TAV and TAV is going to work in that, and so maybe kind of clearing it out and putting a surgical valve, that would be another option. Yeah,
I think the reason that I see it most often coming to me is either there's a very small valve in there and they need a bigger valve, or coronaries. If you occlude your coronaries, what happens? A 50% mortality. no matter what I do, not a good thing to happen. So one of the things about this valve is that it is intraannular. The leaflets are going to be shorter. We can get commissure alignment. And so it would appear to me that the risk of coronary occlusion is going to be less with equivalent anatomies. Now, one of the things, we can all look at the anatomy up front, and somebody that has high coronaries and big sinuses, they're all going to get a second valve. But as the sinuses get smaller and the coronaries get lower, then what are the factors? What would you be looking for to say, okay, well, if this one fails, I can probably, what valve would you want to pick so you would have a better chance for another valve?
You know, I think when you are strategizing TAV and TAV in the future, you know, the most important valve you're going to put in is the index valve. So I think optimizing implant depth and choice of valve up front is one. And if you're smart about how you implant the second valve, you should allow yourself an option for TAV and TAV in the future in many cases.
Another thing I would just point out is that, you know, even if coronary obstruction is not eminent, coronary access can be an issue, especially in, you know, younger patients when you do a TAV and TAV. So something to think about as well.
So, you know, you've seen the really excellent hemodynamics that this valve has. The other thing I like to look at is Doppler velocity index. You know, the EOAs are their measurement, gradients are flow, but EOAs is a flow above, flow below, so it's already indexed to your flow. And with the self-expanding valves for both the Evolut and Navitor, we're seeing Doppler velocity indexes of about 0.6, 0.61, meaning your EOA is 61% of your LVOT, for whatever size you are. Whereas in Becky Hahn's work for a balloon expandable, it was about 0.42. And most surgical valves without annular enlargement about 0.5. And there's pretty good data that the bigger you start, the longer time before they fail, and the better you do it until that time. So I think I'm going to let you sum up, Azeem. I think we've kind of reached the end of your time for what learning pieces should people take away from this.
Yeah, absolutely. Well, actually, I'm going to do it a little differently. I'm going to ask each of the panel to give one key learning to the audience about what they should take away from the session. So, Kamran, we're going to start with you.
You know, I think as Grant showed beautifully in the case, this is a very relaxed and controlled deployment. It's not rushed. You follow the prescribed methodology that Bassem shared with us, and I think you can get predictable and reproducible results in a very relaxed, easy procedure.
Right. Amar?
I would second the kudos to Grant on demonstrating that case. And along Kamran's point, I think if you go back to the on-demand video and you pay attention, you'll see that when Grant started, the marker was just slightly below the non-coronary sinus. And with a very gentle push on the wire, he got it to come to the optimal deployment. It was extremely stable the entire time. It was almost, you know, no offense to Grant, it was almost no effort, right? He made it look so easy. And that's a very, you know, positive feature of this platform.
So even a surgeon could do it. It was so easy.
Bassem?
I mean, my learning point is, I think what I got from this is the only valve that gives us the best of both available worlds right now. There's nothing like that available right now on either platform with the other systems. And to answer Dr. Reardon's question, I have yet to see a Navitor fail. And I've been doing it for many years. So I'm just saying that valve hemodynamics are amazing. We may not need to explant it.
Right.
Great. Well, it's hard to add a lot more to that. You know, from a technical standpoint, I would say, and for those of you who have not yet done it, who are intimidated by learning a new platform, it is second nature. It is easy to do. If you've done Evolut, this is super easy. One of the takeaways about stability that I've learned is just how important it is to make sure your wire is biased to the greater curvature, and the circular wire works really well for that. And whether or not it's Evolut or Navitor, just having that greater curvature bias and implanting in the cusp overlap technique, you know, after recognizing that, I have gone from, you know, partial recaptures to hardly ever doing it anymore and just having a single deployment. So that's a takeaway from someone who is relatively novice at first and now has done a lot of them. But you know, take it up. It's a fun valve to do, and it's really very straightforward and easy to implant.
One quick question, Grant. At the Cleveland Clinic, do you make your surgeon wear loops and a headlight to identify him as a surgeon to do a TAVR?
Yeah, it's a nice touch, actually. Yeah,
So really, I mean, hopefully we've shown you some of the advantages of this technology, and maybe on behalf of Mike and me, we want this technology to be available to patients who are younger and who are at lower risk. So those of you who are involved in the Envision trial, enroll. Thank you so much.
Thank you.